I'm Dr. Corinne, and today we're going to talk about sleep disorders. So this is quite a big topic, and I've tried to highlight some of the important things that you guys should remember. So with that being said, I'm going to start with the introduction. And these are some of the proposed functions that occur during the sleep process. So as we can see here, the body and the brain is being restored. There's an increase in the synthesis of anabolic hormones and a decrease in catabolic hormone production. There's an increase in brain synthesis of nucleic acid proteins, and also memory is reinforced, and this is when consolidation takes place. This typically occurs in two stages of sleep. This is what we refer to as being REM sleep and non-REM sleep. Energy conservation takes place. This typically occurs more in animal models. Some things that it occurs commonly in is in bears, where they have to hibernate in order to conserve energy. We don't see it that much in humans, but there's also a mild train of thought that we can think that there is some energy is conserved during the sleeping process. And then we also see the facilitation of waste clearance in the CNS, and that typically occurs via the glymphatic system. So this is a relatively new term, glymphatic. And previously, it was always thought that there's no lymphatic drainage that occurs from the CNS structure, but recently we picked up that there are glial cells, and these glial cells causes excretion of lymph from the CNS structures. Hence the term glymphatic. There's also a proposed mechanism that this plays in Alzheimer's patients. Patients with Alzheimer's dementia might have a disordered glymphatic system, as well as patients who potentially have motor neuron disease or for some of the frontotemporal dementias. So there are some genes that are proposed to encode this glymphatic system, and if there's a genetic predisposition that occurs with this, we have a decrease in waste clearance in the CNS, and that leads to disorders. There's also the integrity of the synaptic neural activity or network is being retained during the sleep process, and then there's also gene expression and thermoregulation that takes place during the sleep stage. So with that being said, these are some of the functions of sleep, and if we sleep deprive ourselves either by reducing the total number of sleep, that in other words decreasing the quantity of sleep that we have, or by fragmenting our sleep by having brief arousals, that's the quality of sleep. And this typically occurs in patients who have obstructive sleep apnea. What happens here is that these patients have multiple obstructions at night that causes multiple arousals, and therefore they never enter that REM sleep stage pattern. And then they feel very tired the following day. People have done a lot of studies in these, in patients who have been sleep deprived, or animal models who have been sleep deprived. And as we can see here, this is an example of a study that was performed where rats were deprived of sleep for 10 to 30 days. They were still maintained nutritionally, so they were given enough water and food, but they were just not allowed to sleep. And when that happened, all of the rats were dead by day 30. So as we can see here, it's very necessary for maintaining our lifestyle as well as an quality and quantity of life. So as we can see, sleep is very important. So looking at the variability of sleep deprivation, we can see that the effects of sleep deprivation changes amongst different people or different patients. So there's quite a bit of inter-individual variation that occurs. So if you compare yourself to your peers, you might find that one can go without sleep for a significant amount of time and perform relatively fine, while the other person might not perform that well. However, within the same individual, it does seem to be quite stable. And this sort of resistance or vulnerability to sleep deprivation does not seem to be related to demographics like male or female race, for example. And it also does not seem to be associated with IQ. However, there does seem to be a genetic predisposition with some traits like qualities. So in other words, it might be a heritable factor. So acutely, if we do not sleep, what will happen? And here we can see that we can have some cognitive symptoms. I'm sure we've all experienced that mood and judgment symptoms before if we do not sleep or we miss the nights of sleep. And we can also be sleepy and have these what we refer to as micro sleep intervals in between, which I will discuss now. So there are a number of different cognitive effects that we can experience with sleep deprivation. And as you will see, we can see that attention is typically reduced, response times slows down, recall is affected, as well as acquisition of new memories. There seems to be quite a relative lack of awareness to the fact that there's an increased cognitive deficits that we see with sleep deprivation. So there's a limited. So the studies on this is quite limited. So looking at other studies regarding sleep deprivation, we can see there's a couple done, namely on healthcare professionals. So as we can see here, they looked at medical interns after the interns did calls, and it's clearly shown that there's an increase in diagnostic errors that happens after a person has been working for more than 24 hours. And more health studies showed that health professionals are actually having a decrease in performance in diagnostic procedures, like when they perform colonoscopies on patients, and after being on call for emergency procedures the night before, it will result in a reduced detection rate for adenomas. In other words, we can see that performance is quite reduced after sleep deprivation. So that's probably very important for you guys when studying for exams, to help you to realize that staying up the night before the study does not actually help you and might actually impair your thinking on the day of the examination. So interesting, we can see that sleep deprivation has also shown up in biological and functional tests, such as with a PET scan, where we can see there's actually a reduced glucose metabolism and in certain areas of the brain, actually causing dysfunction and underperformance in those specific areas. So as we can see here, looking at mood and judgment, again very important with sleep deprivation and may resemble depression or anxiety. You may have patients with irritability, low energy, poor judgment, decrease in self-care, etc. And all these symptoms disappear when normal sleep is restored. So I mentioned microsleeps. So microsleeps are basically very small intrusions of sleep into our wakefulness state and can last only a few seconds, especially during tasks that lack any physical activity, for example driving. They're not always under the control of an individual, but these are quite dangerous. For example, if a person is driving with an average speed of about 100 km an hour, they can actually travel about 83 meters during that 3-second microsleep. And on studies, driver performance has been shown to be inconsistent and unreliable with sleep deprivation. So that was for acute sleep deprivation. Now I'm going to talk about chronic sleep deprivation. So this occurs when you don't sleep for longer periods of time. So not just that once-off call that you're going to perform of 24 hours, but this happens more on a repetitive basis, where you don't sleep consistent consecutive nights at a time. And definitely again, here you can have neurocognitive dysfunction as well as a decrease in alertness that's being affected. There's definite increase in the amount of accidents and workplace errors that occurs in these patients. And there's also a reduced quality of life. The cardiovascular morbidity is increased, and that was also associated with immunosuppression that occurs during changes and fluctuations in your catabolic hormones. Patients also have an increase in obesity, and other metabolic changes occur as well. So as we can see, occupational errors are common. Car crashes and near misses are seen in shift workers, truck drivers, medical residents, as well as in pilots. And the fatality and injury severity level equates to approximately the same as alcohol-related crashes. The psychomotor impairment seen after one night of sleep deprivation is estimated to be the same as having a blood alcohol concentration of 0.07%. In other words, having sleep deprivation and driving is probably a big no-no, because your level of impairment is probably more than the legal limit of alcohol consumption. And in fact, this can actually make the whole process worse. So if you have a patient with sleep deprivation, in other words, the person is suffering from obstructive sleep apnea, and they're using alcohol in the mixture. This is going to be a disastrous mix of precipitants to car-related injuries or crashes. So the quality of life is reduced purely because patients have less energy. So you're performing less hobbies, less pleasurable activities, having inappropriate naps, and being drowsy all the time, which often results in embarrassment at home or at work. Productivity is also at work is also less, and with having sleep deprivation is typically associated with marital problems as well. So the cardiovascular morbidity associated with reduced sleep chronically, as for example seen in obstructive sleep apnea, is often associated with hypertension, coronary artery disease, myocardial infarctions, as well as angina, stroke, and potential other cardiovascular risk factors. The plausible mechanism would be from an inflammation or inflammatory process that is caused by sleep deprivation. Studies have clearly shown that there is an increase in the inflammatory markers seen in patients who suffer from sleep deprivation. So some of the endocrine changes that we can see with sleep deprivation occurs from an increase in cortical secretion, reduction in thyrotropinin levels, impaired glucose metabolism, as well as leptin and ghrelin changes. And this typically results in an increase in appetite and therefore subsequent increase in BMI. Importantly, seizure thresholds also are reduced when a person does not sleep. So all in all, we can see that having sleep deprivation is important, as it can have serious consequences if you don't get enough sleep in acutely or chronically. So looking at sleep disorders, I think it's quite important, as patients with sleep disorders typically present in three ways. They can either present with a reduced amount of sleep, too much sleep, as well as with movements or abnormal behaviors during sleep. So if they present with a reduced amount of sleep, they have what we term as insomnia. If it's too much sleep, it's referred to as being hypersomnia. And then abnormal movements during sleep is referred to as parasomnias or sleep-related movement disorders. So it's important in this third category to differentiate it from something like seizures. So the International Classification of Sleep Disorders, 3rd edition, has major diagnostic sections with regards to sleep disorders. And this includes insomnia, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm sleep-wake disorders, parasomnias, as well as sleep-related movement disorders, and others. But as I said, all of these present either with a reduced amount of sleep, too much sleep, or movements at night during sleep. So we'll first look at common sleep disorders that result in insomnia. So a good definition of insomnia comes from the American Academy of Sleep Medicine, where it is defined as having an inability to initiate or maintain sleep, where people have early awakenings with poor sleep quality. This can also be associated with a lack of feeling of being restored and refreshed in the morning upon awakening, and is typically associated with fatigue and poor daytime functioning. And this has to be despite giving an amount of adequate time and circumstances to obtain this sufficient amount of sleep. So looking at some of the terminology that occurs for insomnias, we can talk about sleep initiating insomnia, and that occurs when the sleep onset latency is more than 30 minutes. So when someone goes to bed and is just lying there for more than 30 minutes without falling asleep, we refer to this as sleep initiating insomnia. And sleep maintenance insomnia occurs when a person goes to sleep and then wakes up and then cannot fall asleep again for more than 30 minutes. And then terminal insomnia occurs when there's early morning awakenings and when a person has slept for less than 6 hours, but then wakes up before they need to or want to wake up, and then they stay awake for more than 30 minutes at a time. You can also then have a combination of these symptoms. Depression is associated with terminal insomnia. So insomnia is probably the most common sleep disorder, with about 10% of people having persistent symptoms and about 55% of people having experienced insomnia at some point in their lives. So it is associated with a number of factors, like an increase in age, being female, low socioeconomic status, divorce and separation, widowhood, recent stressors, depression, as well as drug and alcohol use. Now, the impact of insomnia is quite significant. They say 22% of people suffering with insomnia report their quality of life as being poor. It worsens comorbidities such as depression and substance abuse. But the other is also true. So depression and substance abuse also worsen insomnia. And insomnia is definitely associated with healthcare utilization, increase in consultations, as well as increase in hospitalizations. I think what is important when seeing a patient with insomnia is to take an adequate history. And you can do this in a number of ways when using sleep questionnaires, sleep diaries, interviewing the bed partner, etc. But what you want from the history is to assess any relevant comorbidities. So for example, a depressed mood, an anxiety, any medical conditions such as cardiac failure or respiratory symptoms that might be affecting a person's sleep, pain or other sleep disorders, or even snoring at night. You might think about obstructive sleep apnea, restless leg syndrome, and other neurological conditions that are associated with a reduced amount of sleep. Now, it's important to ask those questions because a person with pain may not be able to get a good quality of sleep and may be attending to the pain might fix the sleep problem. It is also important to ask about drugs and substances. This can be prescription medication, over-the-counter medication, illicit drugs, alcohol, as well as smoking. Travel is important, which might be on the differential diagnosis for if a person is having jet lag. I mentioned using a sleep diary. Usually we ask the patient to document the sleeping patterns for the next 2 weeks and then bring it at follow-up. Some pertinent points that you want to written on that sleep diary is that the time they went to bed, the time they think they fell asleep, so they can fill this out typically the next day. Approximately how many times and what time do they think they wake up during the night? What time they woke up in the morning? What time did they want to wake up? How they felt when they woke up? The time they get out of bed, and any daytime naps, medication times, meals, and alcohol. So this is a typical example of what a sleep diary should look like. So in this example here, you can see the time of the day. You can see when the patient ate meals or like breakfast, lunch, had a snack as well as supper, what time they went to bed, what time they fell asleep, and what time they woke up. So a sleep diary like this is freely available on the internet and it's very easy to make one yourself. So now with regards to insomnia, we can subdivide them into chronic insomnia, short-term insomnia, and others. So short-term insomnia or acute insomnia would be when the symptoms are less than 3 months. There's often an identifiable cause or precipitant, and they can also be episodic as well. So usually we see this when we have transient insomnia. If you change a person's sleeping environment after some jet lag, if the room temperature is a bit unpleasant, after some medical or surgical illnesses, and other related medications. So most cases of insomnia are actually of the chronic form, and by definition, it's usually more than 3 times per week, lasting for longer than 3 months, and is often associated with psychiatric symptoms, drug and alcohol abuse, and as we mentioned, medical conditions, pain syndromes, and neurological symptoms. And I also mentioned the risk of this association with depression and suicidal behavior. So as I mentioned, depression worsens insomnia and insomnia worsens depression. Typically, depression will cause a terminal insomnia, and treatment of the depression does not always treat the insomnia. So the other way, or contrary to this, is that sometimes if we treat the insomnia, we may have a response to the depression. So if you have a patient with both depression and insomnia, you probably want to try and treat both aspects. Anxiety disorders, PTSD, and substance abuse are also associated. So one often forgets to look at the medication list when listening to a patient's symptoms of why they cannot sleep. So certain stimulants will affect sleep. For instance, methylphenidate, amphetamines, modafinil, respiratory stimulants or theophylline, appetite suppressants, certain calcium channel blockers, certain antidepressants, beta antagonists like propranolol, in other words, the beta blockers, as well as steroids can cause sleep deprivation. So making the diagnosis of insomnia is basically listening to the patient and making a clinical diagnosis. Just based on the history, you can diagnose or exclude insomnia. And as I mentioned, you can use a sleep lock to assist you with this. So when thinking about a differential diagnosis for insomnia, we have to think about short duration sleep, which is a normal form of sleep. In other words, some people do not need so much sleep. However, there's a misconception in that they feel that they are not sleeping enough. One of the clues to this would be that during the day, these patients do not have any impairment, whereas with insomnia, they are often fatigued and there's some form of impairment that occurs. Circadian rhythm disorders. So here you might find a patient, for example, with an advanced sleep phase disorder, where they go to bed and then they wake up earlier than normal. Now this can be assessed if you look at the sleep diary, looking at those weekend periods as well. But you might find that this person actually naturally wants to go to bed earlier and wake up earlier. And if you have delayed sleep-wake phase disorder, to be the opposite of that, where the patient wants to go to bed late and then subsequently wake up late as well. So in other words, they will still, if given an adequate amount of time, sleep enough. It is just because that a person is trying to force their sleep pattern in terms of daily life. So then we have sleep restriction, which is a chronic form. So here we have people that wake up early to go to work. And if these people are afforded an adequate amount of time, they will sleep. They do not have insomnia. And looking at environmental factors, so people living in noisy environments, maybe the room or temperature of the room is not correct, they will also have a disrupted sleep pattern. So management consists of non-pharmacological and pharmacological approaches. However, non-pharmacological is the main and most important way to manage insomnia. So step 1 would be to identify the insomnia, make a correct assessment, and then have non-pharmacological management implemented. So with the non-pharmacological aspect, we especially use for chronic insomnia, where we use things like sleep hygiene, stimulus control, sleep restriction, some relaxation and cognitive therapy approaches, in other words, CBT or cognitive behavioral therapy. So with regards to stimulus control, what we're trying to do here is to discourage learned associations between the bedroom and wakefulness. So as I mentioned, if you try to fall asleep and you can't get out of bed, you go to do something else. And then you have to climb back into bed when you are feeling tired. So you have to try to make that association that the bedroom is only used for sleep and not a working environment. So just a quick word on sleep restriction. So if a person jumps into bed, let's say at a certain time, so let's say that a patient gets into bed at 9 p.m. and gets out of bed at 6 a.m. but only sleeps for about 5 hours during this time when he's in bed, you can work out the sleep efficiency. So 5 divided by 9 gives you about 55%. In other words, they've only slept for about 55% of the time that they were in bed. And if you restrict the patient's sleep, so if you tell them, listen, you're not allowed to get into bed at about 12 o'clock at night, and then basically having 6 hours in bed, sleeping 5 hours, therefore increasing their sleep efficiency to about 83%. And if you can use this to slowly add time onto this, on the patient's sleep diary, to keep the sleep efficiency above 80%. And here you might be able to correct the insomnia now. So as we can see here, there's a whole bunch of relaxation therapies that we can use to help us restore the sleep pattern. And with cognitive therapy, you can identify unrealistic sleep expectations, misconceptions about sleep, as well as the anxiety that occurs with sleep anticipation. So just a quick word to say about non-pharmacological management. We can see it can be a difficult situation to implement, but gets better results than pharmacological therapies in the long run. You will often need to use a combination of these with one another, so sleep hygiene plus sleep restriction plus stimulus control. So the time to use pharmacological therapies is only for short-term insomnia, and when you use it judiciously. So a few days to a maximum of a month, rather than use your Z drugs, so your non-benzodiazepine GABA agonists, such as zolpidem, for example. So they're preferred over your benzos. Using medications for chronic insomnia is generally discouraged, though. So just to conclude with insomnia, we can see it is a very common disorder. It affects the quality of life. We have to take an adequate history and do an assessment, treat the comorbidities, and remember non-pharmacological management. So now that we've covered insomnia, we'll move on to sleep-related breathing disorders. So sleep-related breathing disorders constitutes out of a large category of disorders. So for your purpose, obstructive sleep apnea as the most important sleep-related breathing disorders, and then just to know a little bit about central sleep apnea syndrome, as well as the small effects of obesity hyperventilation syndrome as well. So I'll start with obstructive sleep apnea. So the diagnosis of obstructive sleep apnea is made by patients with symptoms of daytime sleepiness, fatigue, snoring, subjective nocturnal respiratory disturbances, or observed apneas, with associated medical or psychiatric disorders or hypertension, coronary artery diseases, atrial fibrillation, congestive cardiac failure, stroke, diabetes, cognitive dysfunction, mood disorders, as well as having 5 or more predominantly obstructive respiratory events per hour on the polysomnogram. These can be either obstructive or mixed apneas, as well as hypopneas, RERAs, which are termed as respiratory effort-related arousals that last more than 10 seconds per episode. Without any symptoms, signs of medical or psychiatric disorders, a patient needs to have more than 15 obstructive respiratory events per hour to be considered for an obstructive sleep apnea. With regards to epidemiology, it is 2 to 3 times more common in males than in females. It is the most common sleep-related breathing disorder and is associated with an increase in age. As I mentioned, being male, obese, having craniofacial upper airway soft tissue abnormalities, as well as smoking. Notably, not all patients have to be obese. So impaired upper airway anatomy is probably the main cause of obstructive sleep apnea. And here you have to have a static cross-sectional area that is affected, which is smaller than needed in obese patients. And this might be because of the adipose tissue that is deposited over the neck circumferential areas. And other conditions may have craniofacial abnormalities, for example, people with a small chin and an inferior hyoid bone, as well as other throat problems or related problems. So here we can see 2 pictures. There's a picture on the left of a healthy individual, and then there's a picture on the right with a patient that is suffering from obstructive sleep apnea, where you can see that there's a decrease in the pharyngeal size, which is smaller. There's also a retrognaathic chin with a tongue that is large and backwards located in the throat. So one of these scales is the Epworth Sleepiness scale, where a patient has been given 8 scenarios where they need to rate it from 0 to 3 being from no chance to 3 being a high chance of this happening. And if the person scores more than 10, it would be considered for significant. So another screening tool is called the Stop Bank screening tool. You don't have to know the exact details, but basically snoring, tiredness, someone witnessing an apneic episode, having high blood pressure, being obese, or having an age of more than 50 years, as well as an enlarged neck circumference, as well as being male, gives you a score. Putting all of this together, you can get a score that puts you at either risk for having obstructive sleep apnea. So some clinical polls or tips regarding obstructive sleep apnea is that patients do not feel refreshed after they have slept. So they will fall asleep even during the day, having naps, etc. But if you ask them, they don't feel refreshed. They can also subsequently have headaches. So sometimes you're dealing with a patient with refractory headaches. You should always maybe just think about this person might be suffering from obstructive sleep apnea. So the important thing about the physical examination would be to look at risk factors. So trying to figure out, is this person at risk for obstructive sleep apnea? So you can do this simply by looking at the BMI, examining the tonsils, looking at the shape or the face of the craniofacial profile. Look for a small jaw, large neck. With regards to neck circumference, in males, the neck circumference of more than 43, and then females with a neck circumference of more than 41 centimeters. The patients might be at risk. You can also use the modified Mallampati score, knowing that as you progress in the class of Mallampati, the risk of obstructive sleep apnea goes up. Also looking for hypertension and pulmonary hypertension is important. So this diagram is quite important when you want to try to see what's happening with obstructive sleep apnea, and this is referred to as the polysomnogram. So if we look at these points here, we can see that there's airflow happening here as well as airflow happening here. And then there's a period where there's no airflow existing. And this is the apneic episode. And in obstructive apnea, this is the episode that plays a main interest. So we can see that there's corresponding respiratory effort that happens. And then that's associated with a decrease in saturating levels, as we can see here. So these episodes are associated with a decrease in SATs. And there we can see the snoring takes place when the airway starts to collapse. So keeping that in mind, we can contrast this with central apnea. So with central apnea, there's apnea with no airflow, but there's also reduced or no thoracic movements that occur. So you can go through that diagram again. But with obstructive sleep apnea, you will have absent airflow. And with central apnea, you also have absent airflow. Both of them will have reduced saturation levels during this apneic episodes at times. But they can have, and both of them can have daytime sleepiness. However, the difference on the polysomnogram could be that there's obstructive sleep apnea has an increase in thoracic movements, as opposed to central sleep apnea, where there's a reduce in thoracic movements or no thoracic movements occurring at all. So the differential diagnosis for this could be snoring. So some patients can snore without having apnea. Upper airway resistance syndrome, or UARS, which is another type of airway problem, but there's no complete obstruction, as well as central apnea, which we've touched on. And then there's also other disorders causing hypersomnolence. So we tend to treat obstructive sleep apnea with CPAP. However, it is not tolerated very well. A lot of people are unwilling to try it, and approximately half of the patients who do use it and then they subsequently stop. Or they use it for less than 4 hours a night. Other treatments can involve dental devices as well as upper airway surgery, which we rarely use. So weight loss would be beneficial, however, it's quite challenging. And as we mentioned, the sleep problems also play a role in weight gain. So without fixing the obstructive sleep apnea, you might have problems fixing the weight. And some people can try avoiding supine sleeping as well. You can achieve this by sleeping on your side, using pregnancy pillows, or by implementing something that is termed as tennis ball therapy. So what you do here is that you can stitch some tennis balls into the back of your pajamas, and it makes it very uncomfortable to lie on your back, therefore forcing you to sleep on your side. So now we've covered insomnia and the most important sleep-related breathing disorders. Now we're going to move on to central disorders of hypersomnolence. In this group, I'm only going to talk about narcolepsy. So there are 4 important things that I want you to remember about narcolepsy. And these 4 things are excessive daytime sleepiness, hypnagogic or hypnopompic hallucinations, sleep paralysis, as well as cataplexy. And the mnemonic for this would be something that's referred to as CHESS. So cataplexy, the C, hypnagogic or hypnopompic hallucinations, the H, excessive daytime sleepiness, the E, and then sleep paralysis, the S. So these are the 4 features that are mostly associated with narcolepsy. So with narcolepsy, the daytime sleepiness is somewhat different compared to other sorts of conditions of hypersomnolence, in that these conditions, the patients feel refreshed after they've taken a nap. So as I just mentioned, with obstructive sleep apnea, patients do not feel restored or rested after they've taken a nap, whereas with narcolepsy, they feel good after the nap. Then you have hypnopompic or hypnagogic hallucinations. So hypnopompic hallucinations means that you have hallucinations upon awakening, and hypnagogic hallucinations occur when you experience hallucinations just as you are falling asleep. So with sleep paralysis can be quite a scary symptom. So what happens here is that when a patient is awake, but they feel as though they can't move their body, and it can be quite a scary feeling for a patient having these symptoms. You can also have sleep paralysis without having narcolepsy. But in a patient with symptoms of narcolepsy, it's always important to ask about sleep paralysis. With cataplexy, this is a condition where you have some sort of loss of muscle tone, and it often happens with emotions like laughing or sudden crying. For example, if someone is being scared, they can just lose their tone in their legs, and they'll just have complete loss of tone and fall to the ground. So there are 2 types of narcolepsy. Type 1 is associated with cataplexy and low hypocretin levels, and then type 2 without cataplexy, and they typically have normal hypocretin levels. The difference at the moment is not so important for you guys, except that for the fact that you have cataplexy in the one and the other you do not have cataplexy. So in making the diagnosis of narcolepsy, we use the multiple sleep latency test, or the MSLT, which is basically bringing the patient into the sleep lab, and we ask the person to take naps at certain sets of times, waking them up and then putting them back to sleep again in sort of an hourly fashion. And then we can see how fast it takes for the person to fall asleep. So the biggest problem with narcolepsy is that these patients go quickly into REM sleep and have this very short sleep latency. In other words, they fall asleep very, very quickly. So ideally, you want to perform a polysomnogram before we request a multiple sleep latency test, because you want to exclude other conditions like obstructive sleep apnea that could mimic this condition. And also, these patients should not be taking any other recreational drugs or stimulants before they go into the multiple sleep latency test, because this can skew the results. So the treatment for somebody with narcolepsy is obviously to treat them with methylphenidate or modafinil or some of the amphetamines. So we can also use sodium oxybate. So this is an example of a multiple sleep latency test, and we can see here that the patient is having very short sleep latencies. If you look at terms of minutes, we can see that the person falls asleep instantly on the first nap given in about a minute, and then in the second nap half a minute, and the third nap as well as half a minute. The fourth nap, we can see that the patient goes into REM sleep within 1.5 minutes. Okay, so typically what happens is, so it's diagnostic when a person goes into REM sleep within 8 minutes after the onset of performing the multiple sleep latency test, and this is diagnostic for narcolepsy. So I'm just going to give you a brief word on circadian rhythm sleep-wake disorders. So patients who are or people who are traveling across different time zones might experience jet lag. So basically the brain has not caught up onto the new time zone or is still in the previous time zone. Shift workers also working during the night and sleeping during the day interferes with the circadian rhythms as well. And then you can also have 2 other circadian rhythm disorders. Sleep-wake disorders occurs when there's a delayed in sleep phase, as well as advanced sleep phase sleep-wake disorders. And then you can also have an irregular pattern. So on to the next section, I'm going to look at parasomnias, which can be typically divided into 2 groups. So in these two groups, we're going to talk about the REM and the non-REM related parasomnias. So under these two categories, we have non-REM disorders, which include sleepwalking as well as sleep terrors. Under the REM category, we've got REM sleep behavior disorders as well as nightmares. So the importance about REM sleep behavior disorders are fascinating because it can signify a prodromal state of the neurodegenerative conditions that we specifically see that we term as the alpha-synucleinopathies. And these conditions are typically referred to as Parkinson's dementia, Lewy bodies dementia, as well as MSA or multi-systems atrophy, which is a form of Parkinson's plus. Okay, so this is just a slide about this RBD or REM sleep behavior disorders that I mentioned. It can be seen in Parkinson's disease, MSA or DLB. The important thing here is that these disorders can predate the onset of these neurodegenerative conditions and up to 20 years before the onset of these conditions. So looking at restless leg syndrome. So the symptoms of restless leg syndrome is that patients will have the urge to move their legs, especially during periods of inactivity or rest, and these are partially or totally relieved by moving them. It's probably important to exclude other neuropathies or iron deficiency, anemia. It can even occur with just being in the state of being iron deficient without having anemia on this as well. And therefore it's treatable and is exacerbating this cause of restless leg syndrome. In general, we would treat this condition with dopamine agonists such as pramipexole or ropinolol or rotinolol. But it's preferable to start with something else like gabapentin or pregabalin, until which we then can subsequently upscale to the dopamine agonists later on. So looking at periodic limb movements, and I think it's just important to know that they do exist. And in a polysomnogram, finding it here, you can see these typical periodic stereotypical limb movements, and it's important that it can cause sleep fragmentation and arousal, which might impact on the patient's performance and daily functioning. And this will conclude the presentation. Thank you for your time.